here on the webcam, Dr. Paul Plitzinger is a junior consultant at the University Hospital Ludwig Maximilians Universität in Munich, where he is the head of the prostate cancer diagnostics. He did his urology training in the University of Budapest, Hungary, and in Sao Paulo, Brazil, and also in Munich, where he was in charge of establishing a program for transperineal prostate biopsies under local anesthesia. And this program is performing very well today, with over 700 transperineal biopsies each year. Dr. Plitzinger, it is a pleasure to have you here with us today. We are excited to hear more about your experiences in transperineal freehand fusion biopsies under local anesthesia. I'm very much looking forward to hear your presentation. And with that being said, I will give you the presenter rights and give the presentation over to you.
Perfect. Good morning, Astrid. Also from my side, good morning, everyone. Thank you very much for the kind and introductory words. Astrid, as always, Jean has done a great job on getting all of this together. And thank you very much for the opportunity to be sitting here today and talking a little bit about a topic that is very, very dear to me. So the transperineal fusion biopsy under local anesthesia. I named it today Time to Switch because, as everybody knows, it is time to switch. And it doesn't matter if you're right now a experienced urologist that has done lots of these right now, or if you're an amateur trying to establish transperineal fusion biopsy. I think today's talk is going to have a little bit for everyone. So thank you everyone for being here. Well, let's just start here. Of course, I'm a paid consultant for BK Medical, so these are my conflicts of interest for today. We're going to talk a little bit about the perineal prostate biopsy and how it is the new standard of care. We're going to afterwards do a little bit of introduction to BK Fusion System that has been our working force for the past 3 years at University Hospital in Munich. Then also a little bit about biopsy planning and software integration. I'm going to be talking about techniques of local anesthesia because it is a very, very important part of performing this procedure at the outpatient office, and of course key procedural aspects to show you how we do it. We know we have been having very good feedback from the patients, and maybe you can find something there for you as well. So, perineal prostate biopsy, is it the new standard of care? To say it beforehand, yes, it is. But let's go a little bit back also in our thinking about perineal prostate biopsy and ask ourselves the question if MRI fusion biopsy should be done, or is it still enough to perform only the systematic biopsy? So because we see that a lot in Germany, that patients still get a systematic biopsy, only the systematic biopsy based on an elevated PSA test, for example. So the main studies that were performed to answer these questions were, first of all, the precision study, where they saw that after having done an MRI on those patients, 28% were omitted from biopsy all the way. They saw that in the fusion biopsy itself, they had more clinically significant prostate cancer, so a plus of 12%, and less non-clinically significant prostate cancer, which is the thing that everybody wants. The 4M study from Fenderlest saw also very similar data that even almost 50% of those patients that had received an MRI were omitted from biopsy that would have gotten normally a biopsy beforehand. They saw no difference in clinically significant prostate cancer, but 11% less ISUP1 graded prostate cancers. The MRI First trial, as a last big one, saw that by performing the ultrasound fusion biopsy with systematic biopsy, they saw also no difference in clinically significant prostate cancer, but at the end, 14% less ISUP1 cancers. And to sum it all up, with the Cochrane review, they saw that at the end, MRI pathway had its advantages, so 33% of the biopsy could be omitted altogether. They saw less ISIP-1 prostate cancers and a higher detection rate of ISIP-2 and 3 prostate cancers. So at the end, we can say that, so this was also taken by the AAU guidelines right now, so they want us to perform an MRI before prostate biopsy, and when this MRI is positive, to combine targeted and systematic biopsy. About perilesional biopsy, we can discuss that later, but this is basically the one that we are doing right now. So MRI is great. We can say that also fusion biopsy is great. That's why we do that. Let's talk about the big issue comparing transperineal versus transrectal prostate biopsy. Of course, there are complications with both. We all know that. There are some, at some point, infectious complications, non-infectious complications, and there's also a difference about detection. The biggest topic, of course, is the infectious complications. So transrectal, of course, we do the biopsy through the rectal mucosa. So with that, we can inoculate bacteria into the prostate, leading to UTIs, chronic prostatitis, and also sepsis at the end. And with the transperineal approach, of course, we do the biopsy through the disinfected perineum. And when you think about that, I mean, we started doing transrectal biopsies, I think it was in the 80s. I wasn't even planned there, to be honest, but they started to get away from a very normal thing that was, so they started losing all sterility by performing transrectal biopsy. And that is something strange to me, to be honest. But what is the current state of infections in prostate biopsy right now? So for that, I want to show you this study real quick. Is a worldwide prospective study, so 260 centers worldwide, and they're audited since 2010, so basically highest quality standards. And this study has a staggering of 1,615 cases of infectious complications after a prostate biopsy. Let's take a look at the data. So the techniques that are being used is in the two cohorts from 2010 to 2014 and 16 to 19. It is getting more and more the perineal approach, so 2.7 versus 5.8%. Median age is unchanged and median course taken were unchanged, but now comes the problems. Symptomatic complications doubled only in this time span. Antibiotic therapy being prescribed after a prostate biopsy has also been getting a lot higher, so significantly higher. 3% had a fever after a prostate biopsy, and even 2 out of this 1,615 patients died after a transrectal prostate biopsy. Symptomatic UTIs, also just comparing these two cohorts, we're talking here about a span of only 10 years, doubled, and double the amount of patients seek medical aid in an outpatient office. So the authors themselves, they concluded that to reduce the infectious complications and to comply with the antibiotic stewardship, and we'll get to that in a little bit, clinicians should switch to the transperineal approach. Now, this talk wouldn't be complete without having to address these two trials that were published at the beginning of this year. So first of all, it was the PREVENT trial, so a randomized trial that sought out to elucidate which one is now better, or is there a difference between two? So basically 660 patients that were biopsy naive were randomized into two arms, so highest clinical evidence. The first arm was a transperineal fusion arm. So basically, let's just put in here, this one here. without any form of antibiotic prophylaxis. And the next one was the transrectal fusion biopsy arm under tested antibiotics. I already find that very strange to compare these two with each other. So basically tested antibiotics without any antibiotic prophylaxis in the transperineal. What did they do? So they performed a rectal swab testing for fluoroquinolone resistant bacteria. And if they were resistant, that was around 15%, they used from a plethora of other tested antibiotic. So basically just to have the best one for this trial. What did they see? First of all, there were no post-op infections in the transperineal arm, 0%, and only 4% in the transrectal arm. Complications were a little bit higher in the transrectal approach, and the detection of clinically significant prostate cancer was a little bit higher on the transperineal side. But if you take a look, it was not statistically significant. The next one, the PRO-PC trial, that was very well published in the Journal of Urology. Very similar approach, a little bit more patients, so 720 patients, same median age, almost all the same from the other patients, a multi-center study that saw also in a transperineal fusion arm without any antibiotic prophylaxis, compared it to 350 patients in the transrectal fusion biopsy arm. And what did they do? We take a look at the protocols that they used. So everybody that had a transrectal biopsy received standardly the combination, so the augmented antibiotic prophylaxis, ciprofloxacin, so the fluoroquinolone, plus the cotrimoxazole, so sulfamethoxazole and trimethoprim, 1 hour before and 12 hours after. And of course, by doing that, needless to say that in the transperineum, they received no antibiotics at all. Needless to say that also they didn't see any difference in documented UTI, in fever, or antibiotic prescription afterwards. So they concluded at the end that it is perfectly safe to perform the transrectal biopsy, but it is only safe with augmented antibiotics. Or one could also say it is only safe by using ciprofloxacin, because this was the one that they both used in both studies. And that, of course, doesn't comply with any form of antibiotic stewardship program. Using standardly augmented antibiotic prophylaxis, even though there is a better version to do that. And for everybody that works in Germany, I'm not sure that there are German urologists here with you today. We all know this hand. So basically that tells us every time that a prescription drug has some form of side effects that we didn't know of. And of course, we know that in the year 2020, I think it was, ciprofloxacin was banned from a prophylactic setting in Europe altogether. But the main question is, if we do perineal prostate biopsy, do we need antibiotic prophylaxis? Yes or no? I mean, those studies, and almost all of those patients didn't use any form of antibiotic prophylaxis. I can tell you that we at the university hospital, we do not use antibiotic prophylaxis. And these are the data that back us up. So basically the one in the Journal of Urology, also in this meta-analysis that saw no difference at all in almost 4,000 patients. Either they received antibiotics or no in post-biopsy infections. Post-biopsy sepsis also stayed the same. And if you take a look at even more patients, so almost 35,000 patients, they saw no difference in post-biopsy infections whatsoever, using antibiotic prophylaxis or not using them at all. And as I already said, over 95% of the patients that we perform our biopsy on do not get any antibiotics. We tend to administer antibiotic prophylaxis in those patients that are at higher risk of involving a UTI, for example, transplant patients, patients that have a history of chronic bacterial prostatitis, Foley catheters are always a gray area that we don't know if you really need them or no, or if patients already had a sepsis after a transrectal biopsy in the past, according, well, to the white paper from the AUA that was published, I think, almost 5 years ago. The AAU guidelines say that there is a growing body of evidence that suggests this antibiotic prophylaxis may not be needed in transperineal biopsy, but they're still waiting for the final verdict of that. What about other complications? Because, of course, there can be other complications, so non-infectious complications. Hematuria is something that can happen after transperineal prostate biopsy. Hematochexia does not happen anymore. I mean, theoretically, it can happen, but something has to be done majorly inappropriately to have that. Hematospermia is something that almost all patients have. Pain, it can be, and acute urinary retention. So I want to pay a little bit more attention on acute urinary retention right now, because this is something that led perineal prostate biopsy in the past in a little bit shady lights, let's say. This data, for example, from 2018 saw almost 30%, so I think it was 25% of the patients having an acute urinary retention. Why is that? Because they were mapping biopsies, so they took over 40 biopsies with each patient. So just by hearing that, I almost myself got an acute urinary retention. The next one was in 3,000 patients where they compared is taking out more biopsies more harmful for the patient than only taking, let's say, 12 or 14 biopsies. And yes, it was. So they saw around 7% of acute urinary retention. And those patients in 640 cases from the year 2014 saw acute urinary retention of about 2%. So as always in life, reality lies in between those numbers. So probably somewhere around 2% and 6% somewhere. What about PCA detection rate? There was a Chinese study that compared both directly and did a systematic review and meta-analysis on that, and it saw that food sensitivity for detecting clinically significant prostate cancer was a little bit higher, so significantly higher in the transperineal approach than in transrectal approach. And this is something that got into the guideline. So we can say that the transrectal biopsy, in my opinion, really belongs to the past. In the future, the perineal fusion biopsy will be performed under local anesthesia. This is very important. And to sum up just the first part of this talk, we can say that the first biopsy of the patient without MRI is almost never. Of course, we're not talking about those patients with a PSI over 50 and very hard prostate and so on. Of course, this is something else. But those patients that had probably an organ confined prostate cancer, then a transrectal biopsy, we cannot forget that, has an in-house mortality of a radical prostatectomy. There are multi-resistant superbugs. We cannot deny that anymore in the year 2024. And yes, we play a major role in cultivating them. By administering antibiotics that the patients do not really need, we are contributing a little bit on cultivating those superbugs, unfortunately. Antibiotic stewardship here, the big word, something we all as professionals should comply to. The perineal biopsy itself, it is safe. There are excellent detection rates for that. Without antibiotic prophylaxis, it is possible to do that. And simply just by looking at the AAU guidelines, it is recommended. Now, let me introduce you in the second part of this talk to our working horse that we have been using for the past 3 years in our university hospital, so BK Fusion system. So basically, this is a setup that we use. We have here the electromagnetic field generator that is linked to the compact ultrasound machine. What you use to perform the biopsy is a little bit special transducer. So basically it is a linear probe that gives us a sagittal reconstruction of the perineum and the prostate to do the planning beforehand. We use the MIM software, and as you all know, MIM and BK, and now it's all part of the big family of GE Healthcare. So basically all under one roof. How do we do that? Biopsy planning and software integration. So basically to do that, we have a separate working station with the MIM software on it. We need DICOM data from the patient. So it doesn't matter if they got an MRI that is not in-house, and they bring us a CD, a USB stick, or even a online code so that we can get those DICOM informations. Of course, if they had the MRI in our hospital, then we can retrieve them directly from our PACS system. To do that, you can see here basically the DICOM data from the multiparametric MRI that was performed in this patient, retrieved into our system. What we use for planning are 4 sequences. So we use the T2 axial plane, we use the T2 coronal or sagittal plane, and then we use the ADC map and the diffusion weighted images. This is the next step to perform. What we then do is draw the contour of the whole prostate. We start from the basis all the way to the apex. We draw in the urethra for better orientation during the co-registration and biopsy moments. We then have our target, so our region of interest. As you all know, in the ADC, a hypointense lesion, and in the DWI, a hyperintense lesion. So this classic black and white phenomenon, for example, here in this PIRATES 5 target. The next one is to reposition the transducer to a more anatomically correct position. So basically to match the position when the patient lies on the lie to have his biopsy performed. And then we can all send that to the ultrasound machine, co-register, and perform the biopsy of the target itself. Let's dive into the anatomy and really practical tips. So basically, this is a little bit from what I said beforehand. I think there is something here for everyone. It doesn't matter if you're an amateur or a veteran doing that. Everybody has to know this perineal region. Perineal region, of course, this is where we want to go through. And what we do, we use a special technique to perform these biopsies. So it's a coaxial technique, and I'll get to that in a second. But I want to make sure that you see these parts right here. So basically these 2 triangles that are formed here on the left and on the right side, basically laterally of the bulbospongiosus muscle and the issue and medially of the issue cavernosus muscle, and from this superficial transperineal muscle here. There's a small diaphragm here that gets us all the way to the prostate without hurting too much stuff. So these are also the pictures from real body donors, where you see here very clearly the triangles that are formed from these muscles, and here on the a little bit deeper end of these cuts, also here the prostate right at the end of those 2 triangles. We want to perform a coaxial freehand fusion biopsy, but are there alternatives? I get a question get that question all the time, and yes, there are alternatives to doing that. I want to show you here a few alternatives that may be interesting for you or maybe not. The grid, of course, I think is the most common one being performed right now. And we have here very good pros, so we can plan the biopsy beforehand very well. And if everything is well positioned, then it is easy to perform. But at the end of the day, we want to do that under local anesthesia. So that is a little bit harder to do so because we do not have any leeway into holding the ultrasound transducer. And also, there's a lot of pain because you do many perineal perforations. And you will see that when you perform the transperineal biopsy that the punctures through the skin are mainly the most painful ones. There's a low cognitive proportion, and I put that on the con side as well, because the way that you plan, this is the way you're going to take out the biopsy. It is pretty invasive by performing these many perineal perforations. And of course, there are lots of hardware that you need to use. So basically, there's the grid, there's a stepper unit, transducer, and so on and so forth. And this is something that needs to be cleaned afterwards and all that. There are other alternatives as well from the freehand version, and that is, for example, the precision point system, mainly used in the USA right now. So basically, this is a cannula that is fixed onto the transducer that helps you get the biopsy needle in line with the linear transducer, and the handling is fairly easy, and it's also very easy to find the needle. And this is one of the main of the hardest bits when you start doing perineal prostate biopsy, is always to find the needle, and you produce very fast, very good results as well. The anterior targets are a little bit harder to hit because you normally have to put in this cannula multiple times through the perineum. And you always need to leverage the transducer as well because everything is fixed together. So this produces pain in the awake patient. And of course, if you're working in Germany, you know that if something costs 250 euros only to perform a prostate biopsy, it is way too expensive to do that. And it is a single-use device, so basically 250 euros every time you use that. The freehand approach, this is the approach that we perform in Munich. We almost do not need any hardware at all. We have a very high cognitive proportion, and I personally find that very, very good. And we have a high patient satisfaction as well. The good thing is here in the freehand, we can perform a coaxial technique. So basically by inserting a cannula into the perineum, where we can use that as an access point to get to the perineum every time with the biopsy gun. Cons, there are some cons as well. We need very good spatial imagination. And of course, there is a learning curve. The learning curve is a little bit more significant than, for example, with a grid stepper based method. But afterwards, when you use that, you feel free, just like this picture here. Why do we do that coaxially? Because, as I already said, the puncture of the skin is painful. The good thing is, with this coaxial technique, we only have 2 access points to the prostate. So, as I said before, right at that triangle that is formed right here on the right patient side and here on the left patient side. But of course, the bigger the prostates, the harder the biopsy gets. But that's the case also for transrectal biopsy, as we all know. It's all about a good local anesthesia. And I really emphasize that because with that, the procedure will be good or it will be the worst for the patient. But there are very good techniques, and I can assure you that. And I'll leave out all the techniques that were performed before that didn't get too much attention because they were a little bit hard to do. Let's focus on 2 techniques that are very, very good, that really work. The first one is the block of the periapical triangle. So basically, there's a triangle formed in the depth of the perineum formed from the levator ani muscle, the raptus sphincter here on the medial part, and cranially of the anteriorly of the transverse perineal muscle. It is very medial to the prostate, so there are a lot of arteries and veins coming into this part right here. So when you perform this local anesthesia, it is a little bit more painful for the patient. But at the end of the day, when you are through the adenovias fascia on this part right here, you had a very, very good pain control. The next one is the so-called prostate apex block. The prostate apex block is also the one that we like to use a lot and is highly tolerated by the patients. We have a pain that is only very minimal during the biopsy, but when performing the local anesthesia, it is a little bit higher. It's always better when you are behind the adenovias fascia, and you should do that, so you can, with that, anesthetize the complete prostate. And now, for the last few minutes, let's walk you through a biopsy really step by step to see which steps do we take, what do we use, and so on and so forth. So the first one, as I already said, we do a small anesthesia of the skin itself and the so-called prostate apex block. We identify two access points to the prostate on exactly that part that I showed you, those triangles, for the coaxial needle. And this is normally around 10 to 40 degrees from the midline, around 1.5 to 2 centimeters away from the anus. But of course, this doesn't apply to all of the patients because the perineum is always very different from each other. We then infiltrate only very subcutaneously here on this part where the coaxial needle will go in. 3 mils of 1% prilocaine, that's the one that we use, but of course you can use different local anesthesia agents on each side. We then insert the transrectal ultrasound probe into the rectum and rotate it about 40 degrees to the left and to the right until we see the levator ani muscle. And for those that are maybe not familiar with this sagittal plane of the prostate, here on the left side is always cranially, so this is the lateral aspect of the prostate here, and here very professional design the levator anal muscle that you can see right here. What we then do is under ultrasound guidance, we inject 7 mils on each side of 1% prilocaine right before the muscle, a little bit into the muscle, and behind the muscle until you are here into the adenovias fascia. And let me show you a very quick video of that. So this is the live footage of us performing that, always under ultrasound guidance. We go through the muscle, are here behind the adenovias fascia, and give it a little bit more by going back. Let me show you on another patient, a little bit different anatomy, but at the end, still the same. Under ultrasound guidance, we put in 7 mils of lidocaine or prilocaine or what you want before the muscle and behind the muscle, and are sure that the anesthesia will work with that. We then, on those two places here, put in a 15G cannula subcutaneously, and you can use different forms of systems. We use a perfuser cannula. You can use the precision point system or also special coaxial cannulas that are there in the market. This is the setting that we use. We then co-register basically the planned biopsy maps with the live ultrasound picture, and we take 3 probes per region of interest. Afterwards, we still perform the systematic biopsy on all biopsy naive patients. But the main question is, in peritoneal prostate biopsy, where do we take out the systematic biopsy? We came out with a map on how to perform systematic biopsy based on pretty much a few data that I can show you here right now. So the first one is for 2016, where they saw here after radical prostatectomy specimens, they did a beautiful topographical map on where the main prostate cancer lesions are situated based on the Gleason score that the patients had. And we can already clearly see that, as we all know, it is normally confined to the peripheral zone of the prostate here on the posterior aspect and medially, and also a little bit here on the anterior side. The next very interesting study is this one, also by the group of Eminaga from Cologne, that they saw that where the prostate cancers were diagnosed on the initial biopsy, and if there were no prostate cancer on that biopsy and they performed a repeated biopsy, where was the prostate cancer situated? So here also very important that the most prostate cancers that are, here we have to say transrectally missed, are then here on the anterior part. So we want to focus here on the peripheral zone of the prostate, which is something that we did. So basically we came up with a 14 biopsy core map of the prostate, where we take out on each side 7 biopsies from the prostate, strictly confining here to the peripheral zone, and just 1 biopsy then to the transitional zone afterwards. And these are a few live videos of a biopsy. So you can see that the needle always comes from the right side to the left side, and we stay right in front of the prostate here, for example, the peripheral zone anteriorly, and we take out the biopsy beautifully from the apex all the way to the basis of the gland. I hope you can see that. It is not green. For me, it's green. Let me just go back once. Maybe it works. Now it should work. So basically, the first one. The next one here. Also, every time under ultrasound guidance. So the next one a little bit more medially. And the last probe, this was a patient that had a hole at forehand. And we did oh, it's the screen again. I'm sorry for that. Now it should work. Right beneath the urethra. Good. So what about time consumption? This is something that a lot of urologists also say, that it takes too much of a time, it's complicated, and so on and so forth. I can tell you from, of course, we're a high volume center. We're performing a little bit over 700 biopsies each year. So we have a expertise in performing everything. We have to perform everything pretty fast, otherwise we couldn't do that. And I can tell you there is a learning curve to that, but it gets faster and faster. What we do is about 5 patients per day. We have an informed consent that we have to get from the patients 24 hours before the biopsy. We always perform a urinalysis. The planning itself, as I showed you on the computer, takes about 4 to 5 minutes per patient. The material prep that our prep nurses do takes about 5 minutes. The patient prep also about 5 minutes. The procedure itself, right now, we're taking about 7 to 8 minutes per patient, but as I already said, there is a learning curve to that. When you perform the first freehand fusion biopsy under local anesthesia, you will take 30 minutes for that. But in the first 20 to 30 patients, you get faster and faster, and I can assure you that. Cleaning in post-processing is about 10 minutes. So basically we have a in-room stay of the patient of about 25 minutes until everything is done. What are the take-home messages? Perineal biopsy should be implemented despite any possible logistical challenges, and this is a sentence that is stated in the European guidelines also right now. Be aware of the learning curve. There is a learning curve to that. You need a little bit of spatial imagination for that, but you can see you get faster and faster every time you do that. Local anesthesia is unbelievably important. You need skin infiltration and the prostate apex pod, so a combined local anesthesia procedure. And at the end of the day, when you perform 30 to 40 biopsies, transperineal biopsy does not take longer than transrectal fusion biopsies. So basically, the question that we should ask ourselves is no longer if we should switch, but when we should switch. So basically, to help the patients and that we can reduce patient burden and really do a good job. And with this picture of my beautiful team at the University Hospital in Munich, I thank you very much for your attention. Thank you again, GE and UK, for the possibility. And I am very much looking forward to your questions. I hope you have a lot of them. Let's do it.
Thank you, Dr. Pfitzinger, for sharing your insights and for this great presentation. I can see that there is actually someone who wants to ask a question. It is Amanda Kumar. I will unmute your microphone. Please unmute yourself and you can ask your question out loud.
Thank you very much. Hi, Paulo. Good presentation. Very insightful. And thank you for keeping it completely evidence-based. Every step you are trying to show the evidence, which is much more encouraging than a single person's own experience. And you have also beautifully integrated your experience also. I am Ananda Dhanasekaran. I am a urology consultant practicing in Birmingham, England. We do transperineal biopsies. We do freehand technique. The question for me is, we have showed how we are able to create that fusion images by using that MRI images, rendering and keeping it like overlay into your scan images. When you're actually doing the procedure, is it more live so that the targets, when you're compressing with a probe, will get compressed and targets will also move? And is it quite good for you to see the live targets with the MRI overlapping? That is my first question. And second question is, in your recordings, I can see you're not using the dual images, because BK has got a beautiful dual image where we can see both the transverse section and cross section at the same time. So we can orient how medially or how laterally we are by using a cross section, or is it just the recording only happened in this way? Thank you very much.
Thank you very much, Umar, for your question. It is a very important question because when you do that, for the first question, it is really a problem when you do that and you have the wake patient and he's moving around. You will eventually lose a little bit of the co-registration that you took a lot of time beforehand, maybe on producing and making it perfectly. And it is true. That's why we strictly always take out the probes from the region of interest as a first probe, so that we are done with that very fast. The next tip that I would have is that you always co-register from the anterior side of the prostate, because when you compress the prostate with the ultrasound probe, because for everybody that maybe doesn't not know what that means, is when you have the MRI, you of course do not have some form of rectal spool, you do not have a rectal probe inside. And when you do the co-registration with the compressed prostate, it is always a little bit different than it should be. So basically what we do is we then we co-register it from the anterior aspect of the prostate, that the difference when you turn around the transducer is not so big when you in comparison to, for example, co-registering the posterior part. So you can try that out. Maybe there is a little bit difference to that. And that's what I want to take on that. And remind me again of the second question, just one
Yeah,
second.
the second question is, in the recordings which you have showed us very nicely, you are not using the dual screen.
Dual images. So when we perform the systematic biopsy, we very strictly rely on anatomical parts of the prostate rather than having to use the double images. Why is that? Because for us, if you're taking a biopsy out of the peripheral zone, for example, in the systematic biopsy, if you turn the transducer to the side when you can see the peripheral zone, if you can see that, and you can see that on the sagittal image as well, and you take out the probe from that part, it really doesn't matter how perfect it is on the left or on the right. You will always get the peripheral zone. So I personally don't think that the dual image really gives you more of a benefit, just in comparison of using just the sagittal plane. That's why I like to use only the sagittal plane, because I can see all the anatomical structures, and PK gave us a system that has a very high resolution, and you can always differentiate the transitional zone from the peripheral zone. And when you see the peripheral zone in the sagittal plane, and you are sure that you're taking the biopsy from there, why would you need more than that information? So I like to keep everything very simple and in that way. So and I'm sure that the peripheral zone is always inside the probe. So I don't like using the dual image personally.
Thank you. If I may ask another small question. In the initial picture, you have shown that it's like a robotic extra arm helping you to hold the probe. So you are using that extra arm to hold the probes so that it makes your hands free, or there is no need? Okay, there is a big picture shows extra arm.
No, there was one picture of the alternative with a grid that has a stepper on it. But when we perform the freehand biopsy, we have the ultrasound probe in our hand, and with the other hand, we have the biopsy gun and take up the probes. So there's no extra arm holding that. I'm sorry that it led you to that impression. So it's very free.
Okay, thank you.
Harder.
Thank you, Paula.
Thank you so.
Thank you. There was also another question that came in during the webinar, but I will just remind the audience that everyone can still either ask a question live, just click the hands if you want to ask a question live, or you can just write your question in the questions pane, and then we will read it out for Dr. Pitzinger. So the other question that came in early in this webinar was that the EAU guidelines 2024 recommend for PIRATES 4 and above take targeted biopsy plus perilesional sampling. What is your take on that? Will you omit systematic biopsy?
Yeah, my wish is to omit systematic biopsy, but unfortunately we not only have the European guidelines, but we also have the German guidelines. So the German, we're always in a very tricky situation when we do something just strictly by the European guidelines and not do it by the German guidelines. So we still perform the systematic biopsy in the let's say classical fashion, just because of the German guidelines right now. The evidence that we have on the perilesional sampling and the strength rating in the EAU guideline is still weak. So it's I'm not sure that they made up their mind entirely about that. I personally think that it is a good thing. I would like, and we are starting some clinical trials with that as well, just by taking perilesional sampling, and I think that's the way to go in the future as well. But right as of today, if you come by to visit us, you will see the systematic biopsy still applied.
Okay, thank you. And then if you see on your ultrasound a lesion in a different region than on the MRI, what would you do?
That's a hard question. So basically what I would do is, if I see it somewhere else, I wouldn't take out a probe extra from that, or maybe a double probe confining to the systematic biopsy, because by performing the systematic biopsy, we're still almost in every region of the prostate the whole time. So if I see something that looks a little bit suspicious in the ultrasound, and I can take a probe from that according to the systematic biopsy plan, I would take 1 or 2 extra from that place where I think that there's something there.
How do you position the patient for your biopsy?
Very important question. Thank you very much. So we put them in a lithotomy position with a very strict 90 degrees. So the femur has to be 90 degrees up, so that the perineum is completely exposed to us performing the biopsy. And it's very important that the hips, they're a little bit more adducted, so basically turning a little bit outwards, so that opens up a little bit of the perineum as well. It's very important for the patient to help us a little bit, so they need to lie relaxed, if they can, of course. But that helps us a lot, because the natural instinct of the patient will be in that lithotomy position. For most of men is, of course, the first time and maybe the last time being at the doctor in that position. They will clinch the perineum and start lifting their buttocks a little bit higher, and that closes up the perineum, so it makes it a little bit harder for us to perform the biopsy. So strict 90 degrees with the femur in the lithotomy position, and a relaxed patient. That's the way to go.
Thank you. That sounds really clear to me. If there is more questions regarding this, please send them in the chat. In the meantime, there is also Roger Anthony who has raised his hand, and he can now unmute his microphone and ask a question.
Hi, my name is Roger. I'm a urologist based in Malaysia. So I perform a transperineal biopsy using cognitive fusion rather than a software fusion. The model of the ultrasound in my department is also a BK 5000. So I'm just wondering, based on your personal opinion, how much of an added advantage in regards to cancer detection rate if I utilize a software fusion compared to cognitive? Thank you.
Very interesting question. Thank you very much for that. I personally think that if you're performing, let's say, 50 biopsies a year, software fusion helps you a lot on maneuvering around, especially when you perform freehand biopsy. If you're performing more than 300 or 400 biopsies a year, then at some point, I personally don't think you need software anymore, because you have such a good spatial imagination of the prostate that you know your way around. But if you're a low volume center, then my personal opinion is that you really need software, because it helps you a lot. And we saw that as well. We have some data showing that that urologists that are not so experienced, so we have a wider range of urologists performing the transperineal biopsies that are hospital. The ones that were not so experienced, they performed a lot better with the software than the ones that were very experienced. That doesn't matter. Not so experienced. Software is really fun.
Thank you very much. Thank you.
Okay, in the meantime, some more questions came on. Is there any prostate volume threshold for transperineal approach?
I wouldn't say there is, actually. It depends on the anatomy of the pelvis itself. If the patient has a very narrow pelvis and a very small one and a very, very big prostate, of course, that doesn't help. You know, that's when it gets very, very tricky. And it's also very tricky where the lesion is situated. So if you have, for example, a big prostate, that has a very anterior and medial lesion, and you have, unfortunately, with a few patients, a very narrow and small perineum, then you get to a limit. There is not a threshold limit that I would pinpoint only based on the prostate volume, but it's also based on the width and height of the perineum itself. But we did perineal biopsies on basal lesions with 400 cc prostates, and it worked as well. But sometimes it gets tricky by doing a biopsy on a let's say 70 cc prostate if the lesion is on a heart of the prostate and the perineum is too small. So just by volume, I wouldn't say that there is a limit to that.
Okay, then there is Franco Blefari who wants to ask a question. He can now ask his question to you.
Hello, Paulo. Compliments with your presentation. I perform transperineal approach Freehand biopsy since 1986. So the way you do that it's okay. I did that always in my time. The new is the fusion, and I want to ask you, which is, in your opinion, the simplest software to fuse the images of MRI with the sonography?
Well, we have a very... Okay, that's it. Thank you very much. So we have a wide spectrum we're very experienced with the MIM software. What I look for in a software is that it's very intuitive, that it helps eliminate some form of small mistakes that you can maybe do if you're not so experienced in software registration, and also that works really fast, because by doing that a lot, you need to perform that in a best and fastest way that you can. And we have, to be honest, the best experience that we have is with the MIM software, where we have all of these points that I just mentioned. And the good thing about that is that we have a seamlessly integration into all of our network. So basically, with that, we can, at any point in time, we can always retrieve data from the general PACS system in our hospital. We can send that to the ultrasound. So they really work in perfect synchrony. All of those ticks in the box we have with the MIM software, and it's very intuitive to work with that.
Okay, thank you.
And then we have one last question before we end the webinar today, which is for the region of interest. Do you target all lesions or only the highest pyrus lesions?
Also a very important question. What we see is that, let's go back a little bit to that argument with the acute urinary retention, and the more biopsies we take, the more risk we put on to the patient. According to PIRATES 2.1, there can only be 3 targets in the prostate. If there are more than 3 targets, then the radiologist performing the MRI did not do a right job. So basically, you can always have only 3 targets. If you have 3 PIRATES 4 targets, then we will sample all of those targets. If we have only, let's say, one very cryptical PIRATES 3 target in the transitional zone, maybe we won't do 3 biopsies of this region of interest, but we do that biopsy doing the systematic biopsy, for example. So there is a little bit of leeway there, but if there is 2 or one PIRATES 5 target and one PIRATES 4 target, we always will do, we'll sample both. Yes.
Okay, thank you. Thank you for answering all these questions, for going in the discussion, and for also doing a great job on your presentation. Thank you for being here with us today. Also, thank you for the audience to participating in the webinar. We are soon ending the webinar. Note that when we are closing the webinar, a small survey will open on your screen. Please take a moment to complete the survey and tell